Public health surveillance networks are currently analyzing data surrounding a severe viral pathogen, as initial reports indicate that hantavirus mortality rates are tracking at levels significantly exceeding those of standard seasonal influenza. While seasonal influenza in the United States typically carries a case fatality rate well below 1%, historically hovering around 0.1%, hantavirus infections present a radically different clinical profile. According to data maintained by the Centers for Disease Control and Prevention and the World Health Organization, certain presentations of hantavirus carry a baseline case fatality rate ranging from 30% to as high as 50%. This stark statistical reality underpins recent assessments evaluating the survival limits of patients infected with the pathogen. The core concern for global health officials is not the sheer volume of cases, which remain low compared to widespread respiratory infections, but the extreme virulence and high probability of fatal outcomes once clinical symptoms manifest. +1. To understand why this pathogen is drawing such intense scrutiny from public health epidemiologists, it is necessary to examine its classification and behavior. Hantaviruses represent IGIS of enveloped, single-stranded, negative-sense RNA viruses within the Hantaviridae family. Unlike many other zoonotic or vector-borne viruses, hantaviruses do not rely on arthropod vectors like mosquitoes or ticks for transmission. Instead, they are entirely dependent on specific mammal reservoirs, primarily rodents. Scientists classify these pathogens into two distinct clinical categories based on geography and symptom manifestation. Old World hantaviruses, prevalent across Europe and Asia, primarily cause hemorrhagic fever with Raynaud's syndrome, which can lead to acute kidney failure but generally exhibits lower mortality rates, typically between less than 1% and 15%. In contrast, New World hantaviruses, endemic to North, Central, and South America, cause hantavirus pulmonary syndrome, a devastating respiratory and cardiovascular illness where the case fatality rate frequently hits 38 to 50%. +2. The current framing of hantavirus as a highly lethal threat stems from its distinct transmission dynamics and the environments where exposure occurs. Because the virus causes persistent asymptomatic infections in its host reservoirs, infected rodents shed the virus continuously throughout their lifespans. The primary vector in North America is the deer mouse, while other species like the white-footed mouse, the cotton rat, and the rice rat harbor localized strains. Human transmission occurs almost exclusively through the inhalation of microscopic viral particles. When rodent urine, droppings, or nesting materials are disturbed, the viral particles become aerosolized, suspended in the air as dust. Individuals breathing in this contaminated dust can contract the virus, particularly in enclosed, poorly ventilated spaces such as cabins, barns, sheds, or crawl spaces that have experienced rodent infestations. This specialized transmission pathway limits widespread person-to-person outbreaks, but ensures that individual exposures remain highly perilous, resulting in an illness that progresses rapidly from mild flu-like symptoms to catastrophic respiratory distress. In terms of core developments, global public health agencies and clinical laboratories are maintaining a high level of vigilance, utilizing sophisticated diagnostic frameworks to monitor potential clusters and confirm active infections. May 2026, the World Health Organization received official notifications regarding localized clusters of severe acute respiratory illness under investigation for hantavirus links, highlighting the continuous international surveillance required to track this pathogen. Because early symptoms of hantavirus infection are highly nonspecific, mimicking seasonal influenza with fever, headaches, chills, and severe muscle aches in the large muscle groups, early clinical diagnosis represents a major hurdle for medical professionals. Patients frequently delay seeking treatment during this initial prodromal phase, which typically lasts between 1 and 8 days. However, once the virus transitions into the cardiopulmonary phase, the clinical trajectory accelerates violently. The virus attacks the endothelial cells lining the blood vessels, causing severe microvascular leakage, fluid accumulation in the lungs, and acute respiratory distress syndrome. +3. When a suspected case enters a hospital, the medical response requires immediate and intensive supportive care, as there are currently no universally approved, targeted antiviral medications or cures for hantavirus pulmonary syndrome. Clinicians must rely on advanced life support systems within intensive care units, This includes prompt intubation and mechanical ventilation to combat respiratory failure. In the most critical cases where standard ventilation is insufficient to oxygenate the body, hospitals deploy extracorporeal membrane oxygenation, or ECMO, a complex procedure that circulates the patient's blood through an artificial lung to remove carbon dioxide and add oxygen. Public health data indicates that early referral to a fully equipped intensive care facility is the single most critical factor in improving patient survival outcomes, contrasting sharply with standard influenza care, which rarely demands such intensive, resource-heavy medical interventions. Plus one on the laboratory front, specialized reference centers, such as the National Reference Center for Hantaviruses at the Pasteur Institute, and networks coordinated by the Centers for Disease Control and Prevention, utilize strict biosafety protocols to process patient samples. Diagnostic confirmation relies on a multi-tiered testing approach. Technicians employ real-time polymerase chain reaction, or RPCR, to detect specific hantavirus ribonucleic acid during the early stages of the illness. Additionally, serological testing via enzyme-linked immunosorbent assays, known as ELISA, is utilized to identify hantavirus-specific immunoglobulin M and immunoglobulin G antibodies in the patient's blood. In post-mortem investigations, immunohistochemistry is performed on lung and heart tissues to confirm the presence of viral antigens. These rigorous laboratory standards ensure that public health tracking remains accurate, preventing misclassification and allowing epidemiologists to separate verified hantavirus spikes from other concurrent respiratory outbreaks. Public health officials emphasize the importance of contrasting alarming media claims with verified epidemiological data. While headlines declaring hantavirus to be far deadlier than any standard flu are statistically accurate on a case-by-case basis due to the 38% fatality rate, the risk of a broad, uncontained population-wide pandemic remains exceptionally low. The primary differentiator is the lack of efficient human-to-human transmission. Epidemiological studies show that only one specific strain out of dozens known, the Andes virus found in South America, has demonstrated a documented capability for limited person-to-person transmission, usually restricted to close domestic or healthcare contacts. For all other strains, including the widely distributed Sin Manombre virus, the transmission chain terminates with the infected individual. Therefore, while a single case presents an acute medical emergency for the individual and the treating hospital, the broader community faces no immediate threat of an explosive, contagious outbreak akin to influenza. Addressing the threat of hantavirus relies heavily on structured environmental surveillance, rigorous public health guidance, and systematic prevention measures. Because there is no widespread vaccine available in Western countries and no definitive cure, prevention remains the primary line of defense against this high mortality pathogen. Public health departments focus extensively on educating the population on how to minimize contact with rodent reservoirs. Guidance from the Centers for Disease Control and Prevention details specific protocols for cleaning areas suspected of hosting rodent activity. Standard cleaning methods, such as sweeping with a broom or using a conventional vacuum cleaner, are strictly discouraged because they actively disturb dried droppings and urine, forcing the viral particles into the air where they can be easily inhaled. Instead, guidelines mandate that individuals wear protective rubber or plastic gloves and thoroughly saturate the affected areas with a commercial disinfectant or a mixture of household bleach and water. After allowing the disinfectant to soak for several minutes to fully inactivate the virus, the materials must be wiped up with paper towels or rags and sealed in plastic bags for secure disposal. Plus one long-term prevention requires structural exclusion techniques to deny rodents entry into human habitations. Public health officials recommend sealing any holes or cracks larger than 1/4 of an inch in walls, foundations, and roofs using materials that rodents cannot easily chew through, such as steel wool or metal flashing. Additionally, keeping food sources stored in airtight, rodent-proof containers and clearing brush, wood piles, and tall grass away from the foundations of homes reduces the likelihood of paradomestic infestations. In occupational sectors where workers face elevated risks, such as forestry workers, agricultural laborers, and construction crews clearing long-abandoned buildings, the utilization of specialized personal protective equipment, including respirators equipped with high-efficiency particulate air or HEPA filters, is standard practice to safeguard against accidental aerosol inhalation on a broader scale. Vector-borne disease surveillance units engage in continuous monitoring programs to assess regional viral prevalence. Field biologists and epidemiologists systematically trap wild rodent populations in endemic zones, such as the Four Corners region of the United States, farmlands in Central Europe, and rural provinces across Asia. By conducting seroprevalence studies on these captured specimens, researchers can map out geographic zones where the percentage of infected rodents is rising. This ecological data allows public health agencies to issue targeted warnings to local communities, medical facilities, and wilderness travelers before human cases begin to emerge, transforming reactive healthcare into proactive environmental management. Despite decades of intensive scientific research, significant limits to our knowledge regarding hantavirus remain, which public health entities openly acknowledge. The exact molecular mechanisms by which the virus induces profound microvascular leakage without causing widespread destruction of the endothelial cells themselves are still not fully understood. Furthermore, predicting which patients will experience sudden, irreversible cardiovascular collapse versus those who will transition into a successful recovery phase remains a clinical challenge. While certain inactivated vaccines have been developed and deployed in parts of Asia to combat hemorrhagic fever with renal syndrome, no approved vaccine exists for hantavirus pulmonary syndrome in the Americas. Clinical trials evaluating various antiviral compounds, including ribavirin, have yielded mixed results, demonstrating some utility in specific Old World strains if administered exceptionally early in the disease course, but failing to show significant clinical benefit for patients suffering from severe New World respiratory presentations. Consequently, maintaining a calm, evidence-based approach centered on meticulous sanitation and awareness remains the global standard for mitigating the risks of this formidable pathogen. For ongoing fact-based reports on global public health developments and epidemiological tracking, consider subscribing to this channel. In the domain of clinical monitoring, tracking a suspected hantavirus infection requires an understanding of its biphasic timeline. The initial prodromal phase typically lasts 3 to 5 days, presenting with fever, severe myalgia in the back and limbs, profound fatigue, headache, and gastrointestinal distress. Because these features mirror common seasonal influenza, early identification is exceptionally difficult. The critical development occurs during the abrupt transition to the cardiopulmonary phase. Within hours, patients experience a rapid descent into respiratory distress, characterized by a progressive cough and tachypnea. This shift is driven by the underlying pathology of the virus, which selectively targets endothelial cells within the pulmonary microvasculature. The pathogen disrupts cellular barriers, inducing widespread capillary leakage that fills alveolar spaces with protein-rich fluid, leading to severe hypoxia and non-cardiogenic pulmonary edema. To manage this clinical deterioration, intensive care units must employ specialized treatment protocols. Because there are no approved targeted antiviral therapies shown to reverse hantavirus pulmonary syndrome, hospital interventions remain strictly supportive. Clinicians face a critical challenge regarding fluid management. Standard protocols for septic shock typically dictate aggressive fluid resuscitation. However, in hantavirus patients, excessive fluid administration directly exacerbates pulmonary edema, worsening respiratory failure. Consequently, medical teams must balance hemodynamics using vasopressors to maintain blood pressure while minimizing fluid intake. When respiratory failure occurs, mechanical ventilation must be initiated promptly, utilizing low tidal volume strategies to prevent lung injury. In cases where oxygenation cannot be maintained through conventional ventilation, tertiary medical centers deploy extracorporeal membrane oxygenation. This advanced life support modality temporarily assumes the function of the heart and lungs, pulling blood from the body, removing carbon dioxide, infusing it with oxygen, and returning it to the circulatory system, allowing pulmonary tissue an opportunity to stabilize. Simultaneously, specialized reference laboratories utilize multi-tiered diagnostic algorithms to confirm active hantavirus cases and rule out lookalike pathogens. Laboratories rely heavily on serological testing and molecular diagnostics. Enzyme-linked immunosorbent assays, or ELISA, are standard tools used to detect hantavirus-specific immunoglobulin M, or IgM, antibodies, which are almost universally present in the blood by the time the cardiopulmonary phase begins. Laboratories also screen for immunoglobulin G antibodies to map the long-term immune response. To complement serology, reverse transcription polymerase chain reaction, or RT-PCR, assays are conducted to amplify and identify specific segments of the viral ribonucleic acid genome, targeting the highly conserved small or medium viral segments. Due to the high risk of aerosol transmission, strict biosafety protocols govern these facilities. While diagnostic processing of blood specimens is permitted under Biosafety Level 2 conditions using standard engineering controls, any attempt to isolate or propagate live hantavirus strains is strictly confined to Biosafety Level 3 or Biosafety Level 4 maximum containment laboratories. Public health agencies prioritize contrasting sensationalized claims with verified epidemiologic data to maintain public stability. Media assertions noting that hantavirus carries a mortality rate deadlier than any standard influenza strain are mathematically true when evaluating the case fatality rate, which ranges from 30 to 50% depending on the specific strain involved. However, epidemiologists stress that case fatality rates must not be confused with broad population risk. The critical distinction lies in the pathogen's lack of efficient human-to-human transmission, with the singular historical exception of specific outbreaks involving the Andes virus strain in South America, where limited person-to-person transmission was documented among close family contacts. New World hantaviruses do not spread from human to human. The transmission chain ends with the primary infected individual who inhaled aerosolized rodent excretions. Therefore, unlike seasonal influenza, which spreads rapidly via respiratory droplets, hantavirus presents an isolated environmental hazard rather than a highly contagious pandemic threat. Mitigating the threat of hantavirus relies on targeted public health interventions and strict adherence to environmental sanitation protocols. Because the pathogen spreads exclusively via aerosolized particles from rodent reservoirs, traditional cleaning methods present severe health risks. Standard practices such as sweeping with a broom or using a conventional vacuum cleaner are strictly contraindicated by public health authorities. These actions mechanically agitate dried rodent urine, droppings, and nesting materials, forcing microscopic viral particles into the breathing zone where they can be easily inhaled. The mandated approach requires individuals to thoroughly saturate contaminated areas with a disinfectant solution, typically a mixture of 1 part household bleach to 9 parts water. After a minimum contact time of 5 minutes to ensure the virus is inactivated, the material must be wiped up using paper towels while wearing protective gloves. All waste must then be sealed in plastic bags and disposed of immediately. To achieve long-term exclusion, property owners must seal all structural openings larger than 1/4 of an inch using durable materials like steel wool, keep food supplies in airtight containers, and clear brush or tall grass within 30 feet of residential foundations. On a broader scale, systematic environmental surveillance provides the necessary data to predict and mitigate localized risks before human exposure occurs. Public health agencies deploy field biologists to conduct ongoing longitudinal studies of wild rodent populations in endemic regions, such as the Four Corners area of the American Southwest and rural zones across Europe. By establishing trapping grids, these teams capture target species to measure seroprevalence rates. Tracking the percentage of rodents carrying hantavirus antibodies allows epidemiologists to detect shifts in viral density, often linked to environmental factors like increased precipitation or changes in food availability. When data indicates an elevated viral load within a specific ecological niche, public health departments issue targeted advisories to wilderness travelers, agricultural workers, and local medical facilities. Despite these measures, significant boundaries to medical knowledge persist. A primary scientific uncertainty involves the precise molecular mechanisms behind the severe microvascular leakage that characterizes hantavirus pulmonary syndrome. Researchers have established that the virus targets endothelial cells without causing direct cellular destruction, yet the precise biochemical signaling pathways that trigger catastrophic vascular permeability remain unresolved. Furthermore, there is currently no approved vaccine available in the Western Hemisphere to protect against New World strains, and clinical trials evaluating antiviral compounds like ribavirin have shown minimal efficacy when administered during the advanced cardiopulmonary phase. Concluding a report on a pathogen with such a profound individual mortality rate requires a careful ethical balance. emphasizing clear communication over sensationalized alarmism. Responsible public health journalism demands that reporting accurately conveys the extreme danger faced by an infected individual without falsely suggesting an impending population-wide crisis. Because hantavirus lacks the capacity for sustained human-to-human transmission, it does not pose a structural threat to global pandemic stability in the manner of respiratory viruses like influenza. The ethical objective of providing this data is to empower vulnerable populations, such as rural homeowners and workers clearing long-abandoned structures, with the precise technical knowledge required to recognize exposure vectors and implement validated safety measures. By grounding public awareness in hard scientific facts, media entities and public health networks can effectively reduce preventable exposures, ensuring that an evidence-based understanding replaces unnecessary fear. For continued, objective reporting on global epidemiological developments and public health tracking, consider subscribing to this channel.